Good afternoon and good morning, everyone. I'm Nathan Brown, Director of Marketing, and will be moderating the webinar. Few housekeeping items before we get started. We will be sending an ebook of the webinar to attendees after the webinar is over. If you have any questions, please enter them in the questions field of the webinar control panel, and we'll answer them at the end of the webinar. And we will be conducting 2 polls during the webinar. Please take a moment to answer them, because we value your feedback. Today's webinar is Medi-Cal 2020, Spectrumetics for Prime and Whole Person Care. As I mentioned, I'm Nathan Brown from Spectrumetics. The panelists today are Dr. Raj Lakhanpal. Dr. Lakhanpal is CEO of Spectrumetics. He's a member of the National HIMSS Clinical and Business Intelligence Committee. He's a member of the Board of Trustees of the University of Sciences in Philadelphia, and he's also on the governance board of the Medicaid Information Technology Architecture Initiative. Presenting with him will be Mark Bryant. Mark is Director of Sales at Spectrumetics. He's responsible for new business development and client relations. And Mark was formerly Senior Account Executive at both Sun Microsystems and Iron Mountain. Our agenda today, first we'll do an overview of Prime and the Whole Person Care Initiative, covering challenges, goals, and requirements. Then we'll talk about how Prime and Whole Person Care align with the DSRIP program. We'll give a brief overview of Spectrumetics and what we do. And then we'll talk about lessons learned from DSRIP and how they're applied to Prime and Whole Person Care. Specifically, how data is essential to all these programs, the importance of identifying high-impact patients, and also the importance of pushing actionable information. So without further ado, I will turn the presentation over to Mark.
Great. Thank you, Nathan, and thank you, everyone, for attending today. So for my section is really to set the stage for Dr. Lakhanpal to get into the meat of this and talking about lessons learned and how they might apply to your initiatives. But first, taking a step back and looking at needs today and beyond. What we feel to be successful is a lead entity. A lead entity could be a hospital, health system, county agency within California. If you're from elsewhere on this webinar in other states, it could be some type of healthcare entity or provider organization. The key of it is to integrate, to take on risk and to deliver value first. To start to be able to sustain and enable care delivery in the right care settings. And third is to start to tailor your initiatives, your programs to the unique needs of your patients and also to your community of members. And as you look at that as an integrated lead entity, you want to start to align with other programs too. You just don't want to live in a silo. If you're just tackling Prime today and just managing Prime, you want to see what other programs your entity is taking on. And that could be whole person care if you're part of the pilot program or you're evaluating that in the future. That could be UDS measures in California. It could be helping your provider organizations transition to MIPS and alternative payment models like ACOs as well. If your health system has a clinically integrated network, that's aligning measures across those programs as you start to bring in data, maximize its use, and other pay-for-performance programs as well. So making sure that you see across your whole organization what initiatives you're undertaking and how you can start to make that alignment, not only to improve the outcomes, but to maximize your incentives. So in our conversations with some California hospitals and organizations, what we see as some key challenges for Prime and now getting into whole person care is number one, data integration. And I think this is common throughout any program across the country with the multiple data sources as you purchase other hospitals, as you bring in, as you start to employ more physicians, as you take a regional look at tackling population health and working with behavioral health and long-term care and other ambulatory services. How do you wrap your arms around that data and give it back to yourself in a platform that can be actionable to utilize for both measures and analytics? And so that leads into starting to track the status and outcomes of your patients, your populations and your patients, and doing that in a more real-time look In the bottom left-hand side, identifying those that are high risk, high cost, and proactively managing their care. And then starting to look at, from a measure or metrics perspective, how can you start to calculate and report on these measures on an ongoing basis, on a more real-time basis, and then have the ability to drill down into that data to see patient-level data and any gaps in care as well. And then ultimately, you want to have this data and you want to be calculating these measures on an ongoing basis so that you can start to see your performance and not wait to get reports back from the state or whatever the agency might be that might be delayed. So if you're starting to track them on your own, building these measures, tracking them, understanding where there's gaps in that data, you can really improve the performance and ultimately, again, maximize any incentives. And so for California Prime, the transition has begun away from paper reporting into paper performance. And as you see, we're in DY13, which is the measurement period for this calendar year. It's now increased to 79%, or your payments are tied to for paper performance. And now into years 4 and 5 of the Prime program, it'll be up to 98%. So it's crucial to be improving your outcomes so you can capitalize on that incentive and not leave money on the table. And so overall, the goals are targeting your high-risk, high-cost populations for prime and whole person care. That could be for behavioral health, substance abuse, avoidable ED use, members with multiple chronic conditions, post-incarceration, tackling these populations, understanding who out there in your communities has these conditions, has behavioral health issues, is most likely to use your ED as their main point of care, and starting to proactively target them, get them to the right care, engage them in the right way so you can start to reduce those costs and provide overall better care for them. And so what we see, we have significant experience in the New York program under Disrupt. I'm looking at Medi-Cal 2020 and the different pieces, programs, Prime and whole person care and such underneath it. We see considerable alignment between them and what the needs are. First, data integration. That's taking in state data, hospital data, clinical and billing, working with the HIEs, also working with health plans, and being able to capture that data, integrate that data, and have a way to utilize it in an actionable manner. The second is the ability to calculate measures or metrics that are assigned to the program and be able to look across both the inpatient and outpatient settings to see the patients that are affected or tied to these measures, be able to drill down into the gaps in care, be able to submit and report on these measures on an ongoing basis, and then ultimately have the flexibility and the scalability to start to move your program and align it with other value-based care programs as they develop or you take on as an institution. And so a little bit about us, Spectrum Medics. Our mission is to help our clients, our healthcare partners, make the transition from fee-for-service to value-based care. And we do that in 3 ways. The first is the ability to aggregate data across disparate systems. We're system agnostic. We're a SaaS model. We can work with various data sources, and Dr. Lockenpal will talk a little bit about that in a second, and provide you back a data warehouse in order to be able to calculate measures and do other analytics. The second, and really kind of the backbone of our company, is our measurement platform. So we can build, calculate, and help you track measures for multiple programs on an ongoing basis. And the third is analytics, and that can both be for inpatient analytics around operational and financial analytics, but also a big part and the big driver in Prime and whole person care is that population health, helping you look at risk stratification and geomapping to flag patients, flag members of your community, and provide that care before they end up in your hospital or your ED. And here's a select look of some of our clients and key partnerships across the country. Across the top are our relationships in New York State underneath their Disrupt program. They broke their state into 25 regions. Currently, we're working with 4 regions, and we have a 5th in contract. But the four regions are Mount Sinai and Staten Island, who I'll talk about in a second as a case study. We're also working with Finger Lakes PPS, which is up in the Rochester area, and Alliance for Better Healthcare, which is in the Albany area of New York. And then our measurement platform, both for MIPS, for MIPS upcoming, for PQRS, TCPI grants. We're working with a variety of health systems across the country, including LA Care Health Plan for their TCPI grants in California. And then some of our key partnerships for this. So Dr. Lockenpal talked through our certifications with both ONC and the work we've done with NCQA. But we're very proud of our partnership with Haney Solution, which is a division of the Hospital Association in New York. They've endorsed us for previously our PQRS solution and now our MIPS platform. Montana Hospital Association, MHA Ventures, has endorsed our full platform. We're also integrating with 3 local HIEs in New York as part of their district program. And we're integrated with Oracle. We're an Oracle validated integrated partner. So if you use Oracle as your platform, we have a relationship there as well. So my final slide, I just want to give you a quick perspective of the work that we're doing with our 2 of our partners underneath New York Medicaid reform. First is Mount Sinai. Mount Sinai chose us for our measurement platform. We sit on top of their Epic and Oracle databases to calculate measures, both from state data, but also from their hospitals with billing and clinical data, and also provide them custom measures along with that, so they can calculate these measures on an ongoing basis, see how they're performing from an aggregate down into the measured details for each of their partnering providers, be able to see where there's gaps in those measures, and be able to address those so they can see in a more real-time perspective how they're tracking for their achievement points. Then the second is Staten Island Performance Provider System. So Staten Island was a new entity formed out of 2 lead hospitals. We are their IT platform, so we provide them the means to consolidate data from both their hospitals, but also their ambulatory practices, behavioral health, long-term care, primary care, be able to consolidate that and then be able to layer on the measure platform like we're doing for Mount Sinai, but also population health analytics around risk stratification and geo mapping and such, which Dr. Lockenpal will show you some examples in a bit. So that's some background on us as it relates to Prime, whole person care, and our work in New York Medicaid reform. So I'm going to turn it back over to Nathan for our first poll question. Thank you.
Thanks, Mark. So our first poll question today: are the following key areas of focus for Prime projects, which is a priority for your organization? I'm going to launch the poll now. Give everyone about 45 seconds to answer. Okay, thanks everyone. I'm going to close the poll and share it. And it looks like it's a tie between 2 answers: care transitions in home care, and also behavioral health integration with primary care. Thanks everyone for participating. I'm going to turn the presentation over to Dr.
Hello, good afternoon, everyone. This is Raj Lakhanpal, and pleasure to present to you. Obviously, our lessons learned are evolving as we get deeper into New York District, and we're hoping that very shortly we will also sign one of the Prime programs, one of the Prime programs as well. So one of the lessons, and this is a very high-level lesson, but one of the lessons we learned very early on and continue to learn is that the key is data. And it's easier said than done. It's not that easy to get the data and extract it. So aggregation of data that enables, everything you're talking about in your poll as well, behavioral health integration with primary care, care transitions, home care and home care is key. And data. So at least what we're doing is trying to get data from wherever we can get it. Today morning, we probably had a 2-hour discussion with one of the district programs here, figuring out how to get the data. And this is another client we're bringing on board. And so there are different sources of data. Obviously, the best would be if we could get adjudicated claims in a very timely manner. That generally takes long. So what we have learned is that we could use billing data to do a lot of the analytics. Billing data is much more recent. And then also leverage clinical data. So leveraging EMR data in whatever format we can get, whether it's, we could build an extract, whether it's CCD, CCDAs, any way we could get, so leveraging available data, and that's very critical that, we have to leverage available data to calculate performance metrics, to do population health, whatever is needed. What at one of the regions we're doing here is also leveraging public sources of data, and that could be EMS data, 911 data, behavioral health data from schools, shelters, social determinants of health data from shelters, or shelter data would be a social determinant of health. Schools, it'll be around obesity, around chronic diseases, and then colleges as well. And colleges, we haven't done much, except that becomes a very good, opportunity for students to do projects or surveys. So really, the lesson learned was get data from wherever you can get it, however you can get it. If you can't get adjudicated claims data, leverage billing data, leverage clinical data if you can get it. But some of at the conference about 2 weeks back, at the 2 months back at the California Association of Public Hospitals conference, we learned that getting data was a big challenge, and I believe we have been addressing that with our clients in New York. And this is, it's another view of what we are doing with how we're collecting data, different data sets, clinical data, laboratory data, ambulatory data. For example, with one clinic, they have eClinical Works, and we're pulling in data as flat files or comma delimited files. HIE data, doing a lot of work around that, and then claims or custom formats. We normalize it, we harmonize it. We have our own enterprise master patient index. We apply that to then populate an enterprise data warehouse or a longitudinal patient record. So get data whatever way you can, apply some sound data governance, aggregation, and management principles to it. I'm sorry. And then this talks about a little bit more about data normalization, harmonization. So as we bring the data in, we look at sets, value set verification, and we also do client-specific data mapping. We also review the data, and if they're missing data, if there is any other anomalies that are present, we highlight them for mitigation. We generate a report that is received back, sent back to our clients, who are then able to address the anomalies as needed. and then data normalization, harmonization is performed. And then patient data integration with we have a EMPI solution that has been very helpful with our clients here, and it combines both deterministic and probabilistic matching, and has built-in safeguards to prevent false positives. And it combines matching accuracy with computing efficiency for inline execution. So strong EMPI, but before that, normalize and harmonize the data. Once you have the data set, you can do multiple things with it, or you can do as many things as you want. One of them is to calculate the prime WPC and UDS measures. So what the measures you've selected, you can calculate those on a weekly basis, on a fortnightly basis, or a monthly basis. So that, and we generally calculate here on a monthly basis. We find more than that, it becomes noise. And obviously included in that is the behavioral health measures. Included in that will be the primary care integration with behavioral health as well. So that's so that you can make improvements as you go along, not at the end of the year when you get adjudicated claims data. I think we also found out, for example, one of our clients on the East Coast started with DISREP, but their needs have also evolved to MIPS and ACO reporting, as well as a clinically integrated network reporting, so CIN reporting, where they've built, they have contractual relationships with health plans to provide a certain level of quality of care. So the lesson learned for us is that clients may be looking for Prime as a starting point, but are generally looking for a broader solution that helps them address all their regulatory compliance and performance improvement needs in terms of measures, calculation, and reporting. Right. Okay. And this, I love this slide. It's a simple slide. So what this slide talks about is that you need regulatory compliance. That may be, in your case, it's once a quarter or maybe once a year. And then you need metrics to monitor and improve performance with clinical, billing, and other data sources. So this is more near-time reporting so that you can improve performance, and generally done with either clinical data or billing data. What we have also learned is that we have built proxy measures. So on the left side is regulatory compliance, and a lot of these measures are claims-based measures. But to do near real-time performance improvement, you will need to build proxy measures so that you can calculate the same measures using clinical data as well. And this would be quality and cost analytics, population health. And this shows, the ability to calculate data from different sources. So you may need data from if possible, QRDAs, CCDAs, formats, ADT. You can leverage ADT for messaging. Chart abstraction, billing claims data, we talked about that. Intelligent web forms wherever possible. And then, at times, you may need a custom data interface where to the EMR or file upload. So a number of our clients are also sending us Excel spreadsheets to upload as well. So take that data, calculate the measures, do risk stratification, and then report on measures, Prime, WPC, and other programs. And then, we talk about predictive modeling. So this is predictive modeling and visualization. And this is the other component of the three-legged stool: data aggregation, measures calculation, and and predictive modeling and visualization. And here we've taken data, and this is much more, which is, we use Tableau for this, so it becomes very real time. This could be daily or even more frequent than that. Prime patient flagging, population health, you're assigning lives tracking, risk stratification. We've taken the HCC model, and based on our clients' feedback, we have enhanced it with behavioral health components, clinical data components, as well as social determinants of health. So it's become a very robust model that is very specific to the prime population. And then physician scorecards, and then creating a longitudinal patient record as well.
Okay, thanks, Dr. Lockenpaw. We're going to pause and take our second poll question here. Give everyone 45 seconds. What is your primary reason for attending? Okay, everyone, I'm going to close the poll now. And I'm going to share it, the results.
Wow, this is Raj Lakhanpal again. I didn't realize that, I didn't see the questions prior to the webinar. I didn't realize that it was to evaluate solutions. We should have presented our solution then. But at least in our, presented means as a demo, but in our experience with New York Medicaid, and we have now 4 regions that we are actively providing a service to and are in contract with the 5th one, or finalizing an agreement with the 5th one. I think we've learned a lot. And most of the measures required for Prime have already been, and WPC have already been built out. So the second lesson learned, and this is really, I thought this was, I tell you, one of our clients is Joe Conti here, Dr. Joe Conti. He is head of the Staten Island PPS, and he brought us as, we've been working with them for a year and a half, and he said to us, and I remember this is going back probably 7-8 months back, and he said, guys, you're trying to build a battleship for me where I need speedboats. And so one of the things they have done is that they've looked at, yes, we'll build all the things in time, but what are the patients that we can impact the most quickly? And I'm an emergency physician by training, and and I trained in New York City. So a lot of people that we are trying to impact, I was at the receiving end of those patients when they would come to the emergency department at night. So the key becomes, how do you identify those 500? We started with 500 high impact patients, and we looked at them and we said the high impact patients are those that have more than certain number of visits to the ED, more than certain admissions in a year, and also are failing a certain number of measures. And we also looked at measures that impact multiple projects, so that were, if one measure could, or metric could impact multiple projects, that becomes more important. So we identified the high, and we started with the top 500, and now we are up to the top 1,000. And contrary to what as at least has been the general norm, that you start at a population level, you use a model, you risk stratify the patients, and then you put them into care management, care coordination. We've also looked at, let's look at all the patients that are, for lack of a better word, frequent flyers to the emergency department, or are coming to the ED a lot, coming to the hospital a lot, and how could we impact them quickly. So that's what I mentioned here. Hospital discharges could be a good starting point for an improvement process. And in Staten Island, we took a couple of slides from them. The top 500 they're less than 1% of the population. They have one or more chronic disease. They account for 20% of the preventable ED visits, and they account for 20% of the preventable readmissions. And then their level of engagement, 44% are health home at risk, 12% care coordination. A very, very significant portion are behavioral health. And this is a slightly older slide. This is probably 6 months old, and 22% took the PAM survey. And very interestingly, the average spending for these patients, for an average Medicaid patient, is $24K, and for them it's $75K, so more than 3x. So identifying those, trying to address those was, I think, a big lesson learned for us in terms, everybody talks of the frequent flyers, but how do you identify them? How do you then, and what we would do is identify those, then look at the partners who they belong to, and every month send specific reports to each partner telling them, here are the patients, here are your patients 1 through 20, let's say, and these are the ones that came to the ED a lot, these are the ones that were admitted to the hospital a lot and failed a certain number of measures, so that please, for our next report, see if you can reach out to them, bring them to the to your clinic, so that you can address their needs. And this is a very interesting slide about geomapping. Here it shows, in this case, it shows, this is a diabetic geomap. So the higher the number, it's more brown. So here is the largest number of diabetics, and then this is an area which is lesser and very few diabetics in this region. But there's an interesting geomap that we don't have it in the deck today, which showed that the behavioral health patients were all in the northern Staten Island. No, I'm sorry, the behavioral health were all in South Staten Island, and all the clinics were in the north. So, and that was an eye-opener for us to say, look, we need to have the providers in close proximity to where the patients are. The other lesson we learned, there were multiple lessons, but one lesson we learned was that Staten Island had a lot of first-generation Chinese and Liberian population, and who did not speak English. So the lesson was, look, we need to get translators in the area where that population resides. And then, the other thing we learned is, don't say to the partners, here's self-service BI capability. Here is the capability we'll send you data, but you've got to really figure out how to interpret it very well. Give them easily digestible reports. They don't have the time, they don't have the patience, maybe they don't have the capability even to create good, meaningful reports. So as I mentioned, with the top 500 or the top 1,000, we gave them, we provided them reports that were easy to consume, very highlighted which patients they needed to work on, and these were all PDFs. So this was not pulled into the EMR or pushed into the EMR. So these are PDF reports sent in a secure manner so that they can act upon them. And this is another slide that's a little old now. It's about 3 months to 4 months old, but we showed a significant reduction in ED utilization from 14% to 6.3%. That translates to a 55% improvement. Diabetes management, again, that's with health home at risk. So chronic condition and a behavioral health condition. Diabetes management, again, significant reduction, about 42% reduction in ED use. So again, are able to, and it's a journey for us too. So as we advance here, I think we're creating very meaningful outcomes for our clients. Mark, you want to do this? You want me to do this? Okay. So I didn't know a lot of people are evaluating our solution. We were hoping this remained, or not hoping, we were expecting it to remain more of an educational program. So our key differentiators would be that we can help you transition to value-based care. We have a strong competency in Medicaid analytics. Most of Jackie's here, Jackie's our business analyst for Prime. Most of the measures required, more than 60 to 70% of the measures required for Prime and WPC have already been built out as part of the programs in New York State Medicaid. We are certified for all our ECQMs by the ONC, both on the hospital side and the ambulatory care side. And we're also getting HEDIS certification or NCQS certification for a number of the Prime measures in end of Q1, early Q2. And then we have an end-to-end solution for data aggregation, real-time or near real-time metrics calculation and reporting, and then what population health or predictive analytics and visualization. And it's fairly flexible technology that allows you to implement your custom initiatives too. Thank you for your time.
Thanks, Dr. Lockenbaugh. So we've had a few questions come in here. As Dr. Lockenbaugh mentioned, Jackie Bates, who's business analyst here at Spectrumetics, she's going to help answer some of the questions. So let me get started here. First question, do you provide dashboards for tracking whole person care populations related to selected quality measures?
Jack, you want to take this? Okay, I'll take it. Do you provide this?
I can read it.
Yes. The short answer is yes. We provide dashboards for tracking both WPC populations related to quality measures as well as Prime measures. And if you want, we could do a demo later about these dashboards.
Thanks, Ari. Do you work with organizations to help them define a process to exchange data with their partners?
Do you work with organizations to help them define it? Yes, absolutely. Not only we work with you to define a process to exchange data with your partners, we also do significant data mapping to understand where your data is, how advanced your competencies are with data aggregation, and then populate a warehouse and then help you send reports or exchange data with the partners. We are not an HIE. We generally sit on top of HIEs, or we collect data from HIEs if you have a well-developed HIE.
We have time for more. What methods of data collection are you using most with your district clients?
So it ranges from, as I mentioned earlier, from Excel spreadsheets to at one place we have, at one of the hospitals, we have a direct interface to Meditech EHR. At another place, they're sending us, we give them a data spec file, and they're collecting all the data from Epic and sending it to us. So it varies from very simple, basic way, flat files, Excel spreadsheets, to direct interfaces with EMRs. We also have found that getting billing data is very helpful because that, the health system has that. Health system, hospital, clinics have that generally if they have not outsourced the billing, and that can also provide a lot of very good information.
We'll do one more. And everyone, if you have any questions beyond what we answer here today, feel free to reach out to the contact information on the screen to Mark. But final question, once you identify high-impact patients, what capabilities do you have to address and manage them?
So once you identify high-impact patients, what capabilities do you have to address and manage them? So, so the first thing is the ability to collect the data, normalize it, and then identify the high-impact patients requires a fair bit of, competence. We have a data science team that does that. It's headed by an MD PhD who's very, very good. We are not a care management solution. So what a number of our clients have done is, at one place, at one region, they're incentivizing their partners to reach out to these patients, and they've done well with that. Some of the partners have their own care management systems. Excuse me. At other place, at another region, they have selected another care management system. And what we do is we forward the high-impact patient list to the care management system, and then they reach out to them in terms of care coordination. We do identify the gaps in care that are present so that they can make meaningful interventions.
Okay.
And this is Mark Bryant, and there's one other question that just came in asking if we worked with any government agencies, whether it's a county or a direct government agency. So indirectly we have. So in New York we are working with directly with DOH data, taking in the adjudicated claims data directly from the state and processing that data in order to do the measures calculations and analytics. We've also replicated what is needed to calculate those measures based on other data sources to improve the performance of them or giving it in a more real-time manner. But we have not, we don't have a direct relationship with the government, but with an agency, but we're very confident in that area.
Thanks, Mark. So that's all the time that we have. I'd like to thank Mark and also Dr. Lockenthal. Note that we're going to be at the HIMSS conference next month. We'll be at booth 1889. If you'd like to see a demonstration, that'd be a great time to do it if you're attending. You can reach out to Mark to do that or to discuss any other things that you want to discuss with us at the show. Again, if you have any further questions, please reach out to Mark. Thanks everyone for joining today, and have a great day. Take care.